Hi, welcome to BioBalance Healthcast. I'm Dr. Kathy Moppin.
And I'm Brett Newcomb, and today we're going to talk about the diagnostic process. We have talked before, and we've written a chapter in our book that talks about how to be a good medical consumer. And part of that process is to go through a sequence with your physician that we call the diagnostic interview. And there are some terminologies that overlap both of our professions. And actually, when Kathy and I started to talk about this, and she was telling me what doctors are trained to do, I laughed because that's exactly what we train therapists to do as well, and especially in terms of the way you conceptualize the interview and the notes that you take. There is an acronym called SOAP, and I teach my students at the university to take SOAP notes when they take notes about interviewing clients. And you use the same protocol, or doctors are trained to use the same protocol when they interview patients.
Yes. Yes, and that's, they figured SOAP, we could remember that one.
So this is actually a class you take, or it's part of a class that you take in school, and then...
It's not really a part of class. It's part of, this is how you take a note, and then every day it's drummed into your head. This is how you take a note. This is how you interview a patient.
Okay.
And so the notes and the interview are supposed to go in this order. However, they don't always do that, and part of it is that we don't know how to redirect patients. Patients come in and they say, and they tell you everything that happened in the last 3 or 4 months.
Just kind of throw up on the table.
Yeah, basically. And so you don't even have, you can't get in to ask the proper questions like, what's the most important symptom that you have? What is it that you want me to think about while you're telling me all of these pieces of information? Because the first thing is, what's the problem? What is your problem? Why are you here?
Why are you here?
And then...
It's kind of like in an emergency room, they do triage, and they have a sequence of things that they check first, especially if the patient's non-responsive. And so they check that the airway is clear, and they check that... So do
it's
you...
It's a checklist.
It's a checklist. And and if I come in and I'm so vomitous that I just throw out all this extraneous data, or I'm so unaware that I don't know what to tell you. What is the checklist that you go through with me? You want to know about symptoms?
I want to know the primary reason you're there, because that's going to guide everything else I think about. And so to be a good consumer as a patient, then you should think about this list that we're talking about today. Think about it before you walk into your doctor's office. This is how they're thinking. If your thinking is in the same organization, you can get more out of your visit. So, and even write it down.
I'm laughing because I'm thinking about my own visits to a physician. I kind of go to the doctor generally to see what the doctor wants to talk about or what they want to check on.
Because you're not sick. Now, when you're in a well visit, that's different. When you're well, usually you fill out a form and it asks you all kinds of things, and then you fill that out. Doctor kind of goes by that to see if you have all of the wellness signs for your age group, and then he has a plan, or she has a plan, as to what tests you need to make sure you're well.
And keep you in that zone.
And keep you well for that age
But if I go to the doctor because I've got a frozen shoulder that I can't raise and I'm having pains, then I need to go in and talk about that, and I need to think beforehand, did something happen? How long have I been dealing with this? What is my concern?
Have I ever had this before? How did it end up? Just think, because that takes time to think about. And if you think about it ahead of time, you're prepared.
It saves time.
When the doctor says, well, why are you here today?
Right.
Or what can I help you with? Then the patient can say, well, I've had this frozen shoulder and I did it 2 weeks ago and I tried Motrin and it didn't work, and it hurts more when I go up here. I can't lift my arm above this, or if I lift something, it hurts more, it hurts less when I'm sleeping. That kind of thing. Pain's easier to diagnose than hormonal issues,
right?
Because hormonal issues cover so many different questions, systems in the body.
It's more vague and systemic, as opposed to acute or discrete.
But most of our doctor's visits are for a specific reason. If it's a problem visit.
But it matters because so many general practitioners, in particular, are mass production systems. They've got 7 minutes to get you in and out.
It's not their. That's not their fault. The managed care system has given them basically 7 minutes to get you in and out.
And obviously, if there's a greater concern, they stretch it. They have that relationship.
We all have
but they try to go in that sequence. And so to be a good consumer, it helps if you've thought about these issues before you go in, because these are questions that need to have an answer.
Well, I used to take my mother-in-law to the doctor, and she would She's my favorite relative. She was my favorite relative. She's passed on, but she would go in and start with what she had for breakfast 3 weeks ago, and she'd use the whole time up, and she wouldn't let him intervene. And I'd be going, Ann, tell him why you're here, and she'd just keep going. And so the whole visit was this bunch of symptoms that nothing really related to why she was there, and so she wasted her time with him.
Yeah.
That just had
And that
nothing
didn't
to
help
do with it.
him help her.
No, I mean, he didn't even know which way to go.
Mm-hmm.
So that's probably the most important thing is think about all the things that you think might have contributed to this.
Mm-hmm.
Even tell your doctor what you think it is. I think I've dislocated or I've ripped out a whatever. I don't know. I don't do shoulders. But tell them what you think it is.
I was laughing because many years ago, in the early days of television, Marcus Welby was a major national television show, and they actually had journal articles that would come out to warn physicians about what they call Marcus Welby syndrome, where people would watch the show and then the next day they'd call their doctor and they'd have all the symptoms that Marcus had dealt with the night before, and they wanted to know if you were a good enough doctor that you could
figure it out.
Figure out what
just
he
like
figured out.
So you should always watch that show.
Yeah.
So, but that's the initial thing. Most diagnoses are made from history, and that's in the first part of your visit, which is the S,
Right.
Symptoms.
Okay.
And then the second part of your visit is usually your vital signs, your weight, which are objective kinds of pieces of data, or your exam. And my exam basically in anti-aging is looking at the patient, watching them walk in, how they sit, looking at their face, their skin color, their thyroid. Now everybody's going to be paranoid when they come in my office. But look at how their hair's growing. Is it thick? Is it thin? Is it receding? Do they have hair on their hands? Do they have
Check
hair
their
on
fingernails to see if
Yeah.
they have ridges, if they have spots.
Or if they're all torn, or if they've been chewing them, the anxiety kind of thing. So you can see a lot if you just look as a physician at the patient. So here's the problem. Now everybody's typing on a computer, which is a problem because you should be spending your time staring at that patient, figuring out what's wrong with them, and all of those things that you were trained should be running like a computer in the back of your mind.
Absolutely.
And not the patient, the doctor. And I'm thinking about all the different things it could be, and my mind is picking out.
That's fascinating because that's exactly what I train students to do who want to be therapists. You don't take notes in the session. Pay attention to the client, look at them. You have to be a trained observer. You have to have an experiential database that says, if I look at this and I see that, that's a signal. It's a warning sign. Right. Let's go talk about that. And so when doctors don't do that, they really miss an opportunity to get information that may be critical.
Yeah, they may miss your diagnosis by not looking at you. So, I mean, I've not gone to dentists who didn't look at me while they were turned away and writing like this, and I'm like, how can you tell how I speak, how I'm using my teeth? That's what they do, and see if they're misaligned. You can tell that by watching someone talk.
But you're talking about objective observations, and you're talking about more subliminal observations. Do I wince? Do I move stiffly? Do I hold my head? Can I turn my neck? And you may ask me that question, and I may or not know the answer, but you will have an observation. But you also take weight and blood pressure and temperature.
If you're doing a normal physical exam, in my world, it's more about looking at the patient, talking to them, looking at laboratory data, and doing an extensive history, because I get more of my diagnoses through that in the lab. And the lab is the part of the O of the SOAP. It's observational, it's objective, and it's something that is not going to change. It's right there on paper.
And you don't do prostate exams?
No, I don't. I have all of my male patients, because I'm a gynecologist, go to someone who's done prostate exams for the last 20 years.
Who knows what they're looking for. It's that objective observational experience.
Right.
Okay.
Right. And so for me, my exams and evaluations are different. My objective data is that lab in front of me, and I see that before I even see the patient, but I have to put it both together to get an idea of what's wrong. So I think about what they told me, I think about what I'm observing, I think about all the objective data if I were examining them, and sometimes I'm feeling their thyroid and things like that. All of that is objective.
You have that lab and you have that history if you've had previous encounters with that patient, but if it's a brand new patient, when do you make the assessment part to say, well, I need to get a lab, a blood test, some other kind, an x-ray, whatever it might be?
I actually make people, I actually have people get lab before I ever see them to see if their lab's in the range. That sorts out all the people who really don't need to see me but need to see somebody else. I save them a visit that way.
Okay.
And so then I know that they've got hormonal imbalance.
So even a first-time visit, you would have that information.
Right.
Okay.
I do. And then the A is the assessment. That's a part where you go, okay, history, physical, observational, lab, everything I've got, what does that make me think the patient has? Okay. So then I have a list. Doctors call it a differential diagnosis. That means there's a whole list of diagnoses that patient could possibly have. And then it's my job to either order tests or order a trial of a medication and then bring them back and see what the test showed, how did they feel with the medication, see if I've changed anything or if I've made them better. This is assuming a non-emergent situation. This goes a whole lot faster in the ER. But in the office, this is office practice we're talking about. This is how we do it. And then we want you to come back for the lab generally because then we've got to discuss what we want to do for treatment. So our plan, the P in SOAP, has to do with all of the things we want to do to figure out which one of those diagnoses is true. And we have got lots of choices, thousands of blood tests, x-rays, ultrasounds, management with medication to see how they feel or check blood pressure afterwards. So there's all kinds of plan you can have. My most important take-home message on this is don't leave your doctor's office without a plan unless he says you're well on a well person visit, you're well. You're healthy, but if you have symptoms, you should say, what is the plan?
Okay,
it
so
is
the doctor says
acceptable to say
your
that.
weight and your blood pressure are creeping up. You're not in a range that's critical or of immediate or emergent concern, but you're in an age group where those become issues. We're looking at, a diabetic history in your family, and so we want to get your blood pressure down, we want to get your weight down. So you have a plan for doing those things.
Should ask what the plan is because normal non-doctors don't know how to get their weight down and don't know how to get their blood pressure down.
Right.
They don't know the importance of salt. They don't understand any of the importance of diet in general. The general population doesn't. So you have to tell them what you want them to do as well to try to accomplish the goal.
When you say you have to tell them what you want them to do, let's use...
I'm doing some things, which is testing.
Okay.
My
so you have to
patients-
tell me what you want me to do, or I have to ask you?
No, generally the doctor will tell you what you have to do. This would be more like the end of the second visit. We already know what you have. We know what the problem is. We've done the testing. You're in the second visit. We ask the same kind of questions, how do you feel? Is there any difference? Then if you've tried a drug, then we go down to the bottom and say, okay, here's what we're going to do.
Right.
I now know what you have. I now know what we want to do. I now know that we're going to have to do diet and exercise and this medication. And I want to repeat testing in 6 months, and I want you to come back in 6.5 months. That would be a reasonable plan for a follow-up visit to that one problem. So I know that you have different plans for your patients when it's counseling.
Yeah. But again, I'm assuming it's similar. The patient is involved in devising the plan. When we talk about the issues that they're presenting, the symptoms, the problems, the observations, all of that, then we talk about what do we think needs to happen, and are they willing to focus on that and try to do that. And part of that dance is to figure out what they're really going to do, because a lot of people are non-compliant. They'll say, oh yes, I will do that, and then they don't do that. And so, in terms of a physician, if you were to say, all right, I'll need to see you in 3 weeks or 3 months, and I want you to cut back your caffeine consumption by 2/3. I want you to cut out your salt by 80%, and I want you to lose 10 pounds. And I go, okay. And then I leave, and I don't do any of that. Or I don't do that well. I don't do enough.
That's why we have
that.
a follow-up visit so that we know if you've done it, and then we can say, why didn't you do it, or did you do this? Sadly, it's kind of like being a parent. You have to check on the person that you've told to do the chore or whatever, that they have to change their lifestyle. Lifestyle changes are the hardest thing to get somebody to do. So giving them help, like a medication or a particular diet that they can look at on a piece of paper, is helpful. giving them some guidelines that they can look at. Now, not everyone's going to do it, but it's their health. It's not our health.
Right.
And so they have to understand it's not going to get better if they don't change things, because I can only change so much.
Well, exactly, because a heart surgeon can come in and clean out the valves and say, all right, we've done this, and that's going to buy you 10 years, but if you don't change your lifestyle, it's only going to buy you 10 years, or it's going to buy you less, and we're going to be back at the same place, and you may die. And in that setting, when people are afraid, they're much more likely to be responsive. But when they've gone for a period of time and they're somewhat symptom-free, then they start to drift away from disciplined behavior. Lifestyle changes require discipline. You're more likely to get that discipline if you have an informed and involved consumer. So if I talk to you and you can explain to me from your knowledge base why this matters and invite me to participate, if I buy into that, then I'm much more likely to follow through.
That's right.
And so part of your dance is certainly to know the things that you know, but part of it is the skill of convincing me that I need to do these things for my own survival or for my own good health.
With doing BioBalance pellets, with doing hormone replacement, it's so much easier because I replace the hormones and it gives them enough energy and enough positive reinforcement where they go, oh yeah, that worked.
Right.
So now whatever else she gives me is going to work. And instead of just saying, yeah, they always told me that diet stuff is going to work. But so then
you
it's
find
my goal.
there's a predictive value if you can say, all right, but you're going to take these pellets and in
I'm
about
a
3 weeks,
racehorse
you
that's
should
won
see
a couple times or won once, you're going to
Yes.
bet on me again.
Absolutely.
So I have a 95% success rate with the hormones. So somebody's going to look at me and go, well, I guess I'll follow her diet. So I better be darn sure that I'm right on the diet. I better be darn sure that I'm right on my lasers and my skincare, because
Right.
I am now risking the fact that I might not be so successful with those. So I make sure that they work, or that's why I don't want to lose credibility with that patient. It's very important.
I think a 95% success rate is phenomenal.
It is.
And that's both through self-reporting, people that say, I am experientially satisfied, but it's also through follow-up labs where you can say the test results
The
were
cholesterol's
this
better.
and are now this.
Right, the hormone levels come up, but the cholesterol's better and the blood sugar's better, and people are pulled away from the edge of getting
So
diabetes.
it's not just a subjective experience.
No.
So it all begins, this whole process, this journey to better health, to being able to resist the inroads of aging, begins with a good diagnostic interview.
Right.
And that involves the SOAP approach, and a critical part of that SOAP approach is the observation. The doctor's got to sit down and look at you and talk to you and pay attention to you. And hopefully this podcast will help you be aware of those things and seek out providers who provide those kinds of interventions and treatments for you. If you have questions about this or about any of the information that you were exposed to on these podcasts, you can reach us
At biobalancehealth.com on the web, or you can call our office at 314-993-0963.
and you can reach me at my blog, brettnewcomb.com.